Hello, and thank you for joining me. My name is Mercedes Cassidy, and I will be guiding you through a case study of Sierra Leone and the inadequate response to the Ebola virus disease during the 2014 to 2016 outbreak of Ebola, and how this response may be able to teach us about the future of public health infrastructure and what this needs to look like in more countries than just Sierra Leone itself. To start, why did I choose Sierra Leone? And it's because Sierra Leone is one of the poorest countries in the world, and there is much that can be learned from it. So within this, because Sierra Leone is one of the poorest countries, and because it was one of those in West Africa that was impacted by this outbreak, I believe that through an evaluation of the responses there, that we could learn about the failures in public health infrastructure that occurred here, and then see how that might be able to apply in other places or in the future to this country. So ultimately, the final question is, how do we address these issues in the future? How can we first learn and then address? So to do this, through this case study, I chose to examine the history and the infrastructure prior to the Ebola outbreak to get an idea of how the systems were functioning, why they were functioning the way they were, and then continued to evaluate the changes that occurred during the outbreak during this period of 2014 to 2016. And then finally, using this prior knowledge of its history of and the infrastructure, these changes, coming to a set of conclusions and ideas for changes that could help address and prevent infrastructure failures or issues later on in Sierra Leone and potentially in other countries. To begin, I would like to provide said background to make sure that we all understand what is going on, what did the infrastructure look like, what was the history like, the social and the economic factors, so on and so forth. So to start, to get an idea of the geography, Sierra Leone is located in West Africa. We have Guinea to the north, Liberia to the south. And it was one of the countries that was indeed most affected by the Ebola outbreak of the pandemic in 2014 to 2016. It is bordered by Liberia and Guinea. There are three main cities that I have noted here, and this is Freetown right here, which is the capital, Bo and Kenema. And Freetown is actually where the majority of the people actually live in this country. And this is closely followed by Bo and Kenema. Now I'm pointing this out now because the total population of Sierra Leone is about 7.4 million people. And this is an important number for later on when we're discussing the amount of healthcare providers that should be present to address the health needs of the population. And this applies to public health structure as well. So I have pointed out Freetown here for you to look at, but this is a population density map. And I thought that this was pertinent to provide so that we don't just know where some of these cities might be, but we know where people are localized. So a lot of these lighter can regions have between 1 to 25 people per square kilometer. And it's in these dark spots where we see a higher density of people per area. And this is important because later on, when we talk about the how spread out the medical resources are in this country, and this is important because these medical resources are mainly localized to these very, very specific areas where people live, and particularly these big cities like Freetown, Bo, and Kenema. And in fact, that will be where we're looking at the largest facilities. So with the geography and the population density in mind as it currently stands, in order to understand where they have, how it's come to be here, we have to have an understanding of some of the political history. So this starts here, where the United Kingdom was originally in control of Sierra Leone, but Sierra Leone gained their independence from the United Kingdom in 1961. So that's not that long ago. And this was after 150 years of colonial oversight. So that's a long time to have another country running your own government for you, changing all those systems, implementing all of their own ideals in that place. So after they gained their independence from the United Kingdom, they did suffer years of dictatorial rule after this. And this meant that it culminated in the 1970s in the form of an economic decline. And this actually resulted in the country going for months without electricity. So we're talking in an era where you have like landline phones that exist or other forms of technology that are starting to come online. This isn't happening here. And so simple things like light bulbs aren't even functioning. So that puts it in perspective. If that's the problem already in the 1970s, then what could be other issues stemming from that that will carry on even 60 years into the future? After the economic decline here from 1991 to 2002, there was a civil war. And during this time, I wanted to point out that hospitals were actually ransacked and they were used as bases for some of the rebels. In the cases where they weren't just ransacked and used as bases, they were actually burned down completely. That's a problem because now we have not only a reduction in human life, constant fighting, destruction of infrastructure, all the settings of that infrastructure, those facilities are also being destroyed. And this is important as well because people moved from countryside to urban areas because they were afraid of the fighting that was going on in the countryside. So now we have a lot of people stacking up in very close quarters with one another. Some hospital facilities are not even in existence anymore. And then what results from all of that? A population of people that tend to have mental illnesses that result from that, whether that be PTSD, anxiety, those sorts of issues. And that impacts the overall health of the population, not only in a day-to-day matter, but in dealing with the crises as they come along. And interestingly enough, because this was so recent in the last 25 years, that's going to be something that will also eventually play into how they might respond to an outbreak of another disease. So now that we understand the political context, let's look at the social and the economic. So during that colonial period, African people were really not given attention or aid, which makes sense in the context of global racism. They were actually viewed as harbingers of disease themselves. So almost another pool where people might acquire infections, but we know this isn't true. It's still a problem though, because it means that they weren't given resources even then. Continuing on to the present though, the country relies heavily on agriculture for the economy. The problem with that is, while it may be somewhat lucrative, the average income is only $513 per year. And that's as of 2019, 2020. And that is significantly lower than what you might see in other countries, giving credence to the fact that they are in fact one of the poorest nations in the world. So this also has implications for the ability of people to live and thrive in the country. So on a salary of $513 per year, how are people expected to be able to pay for medications that may cost triple that number, or to get services that may be a fifth of that number, yet still be able to survive day to day? It's an important matter here. And currently, Sierra Leone actually raises 11% of its GDP, or gross domestic product, in taxes. Now, their goal is 20%, and that's to make sure that the country itself is getting enough income in so that they can pay for their own maintenance of their own systems, paying for jobs, all of that. And since it's so low, that gives the idea that maybe this isn't happening, that there's not being enough money delivered out in certain areas, which is true. Because compounded on that, there's a study that found that the country will lose $44 million per year due to tax exemptions. As in these global conglomerates, these large companies that work within Sierra Leone are being exempted from paying taxes to Sierra Leone. And instead, Sierra Leone is losing money to them. And they will actually abuse this system. And this is on catastrophic levels. So there's an estimated loss of $200 million from 2010 to 2012. And this cost 14% of the GDP in 2011 and 8% in 2012. While there is a decrease, this is a significant amount of money and a significant percentage of their gross domestic product. And there was also this illicit financial flight, and it's also called profit shifting. And this is where these companies will actually shift where their profits are to different branches of their own company to avoid having to pay taxes on them. And that's thought to have cost another 12% of the GDP over this time frame. To put this into perspective, though, we want to know about how this impacts health infrastructure and public health infrastructure. That's 10 times the health budget of $25 million, and it's spent on tax incentives for other companies. And so there's a lot of money that is not being spent on the maintenance of critical structures to the health of the people, and is instead being spent on maintaining some sort of economic ground, even though that ground really isn't being maintained because the country is being abused for it. So we have a political context. They recently gained independence. They suffered from dictatorial rule. There's economic issues. There's issues with the way that the people might have been treated socially before this that may be impacting today's world. So what does this public health and healthcare infrastructure look like? And the healthcare infrastructure is designed for primarily primary healthcare, meaning the level of a doctor's office. And because of this, they focus a lot on that avenue of healthcare, and so the country lacks a lot of major centers for surgery and emergency medicine. Those are also expensive to be able to implement. We know that the economics of the country are not well established. There's not a lot there. So it makes sense that this would not be there. The major centers for surgery and emergency medicine will also not be present. And in fact, there are only 3 large hospitals with surgical units and laboratories. And that's where I pointed out Freetown, Bow, Tenema, that's where these hospitals are located. And they're not even close to one another, and they don't really have any proximity to a lot of the rest of the country. One of them is in fact on the coastline. And so that's a big problem, and especially when we're talking about them being the only ones with surgical units and laboratories, which would be performing essential diagnostics as well. Now, the country is divided into 13 districts, and each of these has its own health management team. And this has about 100 technical staff associated with these health management teams. And they work with public health. They also work with the regular healthcare infrastructure. All of it serves a dual purpose. And so much of the primary healthcare actually carries out a lot of what we'd associate with public health. So that would include disease surveillance, transmission tracking. All of these important concepts that we're going to find are critical in order to have an effective response to public health matters, so matters involving the whole population. With that in mind, these are some statistics from 2019 regarding what the current numbers are for healthcare providers themselves. And there are currently 1.4 doctors, nurses, and midwives per 10,000 people. The goal is actually 44.5. That is a significant deficiency in healthcare providers. And that overall means a shortage of over 32,000 medical workers. So imagine that we have 1.4 doctors, nurses, and midwives per 10,000 people. That's about 1,100 healthcare providers total within a country that needs to serve 7.4 million people. That's a deficiency. In fact, what we call that is a medical desert, because there's a lack of facilities, there's a lack of people, even there's a lack of healthcare that's available for these people, and adequate healthcare at that, simply because of these issues. And this can be brought back to this whole idea that there's not the economic basis for this. They can't fund, they don't put the money towards funding their healthcare infrastructure. So a lot of this isn't going to be here, and they may not have people who feel like they can work because they don't get paid, or they can't even pay for the training of personnel, hence a personnel shortage as well. with that in mind, the healthcare system has its own divisions within it. So yeah, there's the districts that the country is divided in politically and economically, but what does this look like for healthcare? And it has two divisions. So there is a peripheral healthcare unit, which is called a PHU, and there's multiple of them. In fact, there's 21 of these there are groups of these peripheral healthcare units within the 21 districts, which comprise secondary care facilities. And this is where we also see 3 referral hospitals throughout the country. It's at this broader level. And these districts oversee these peripheral healthcare units that are comprised into their own bundles. And these peripheral healthcare units are actually further divided into maternal and child health posts, community health posts, and community health centers, which is hard to imagine since there's already a personnel shortage for healthcare. How can you have all of these community-based divisions? They exist, they're there, and that's to make sure that they're delivering these necessary resources to the people at the ground level, but that may not be happening like it should. And then it's important to note that these healthcare centers are run by community health officers who are trained to be able to make sure that all of these units function, and they will also work at this district level to make sure that the secondary care facilities are in contact with the peripheral healthcare units. Now, there are 45 private clinics and 27 private hospitals in the Freetown area alone, but that yet again is just Freetown. That's one city for a whole country. And those are not spread out everywhere else. And that makes sense because of the urban areas where most of the population is, it's not going to be spread out everywhere else. Lending credit to that idea of a medical desert. Again, most of these healthcare professionals are going to be in these populated areas. And as a final note throughout the rest of this case study, I will be mentioning the MOHS, or the Ministry of Health Services. And they are the entity at the governmental level that is responsible for handling issues of public health and its implementation. And they largely do rely on the healthcare system and its workers for some of this implementation because there simply is not the manpower to be able to do it any other way. With that, we know the history, political context, economical context, social context. We know how the system works. We hit 2014 and Ebola is becoming an issue again. It has showed up prior to this in 1976 in other countries. It is a zoonotic disease, so there are incidences of spillover occurring where this disease has jumped from an animal into humans. And throughout all of the infections that have happened, the outbreaks of Ebola that have happened, it has been noted that the average case fatality rate, or the number of people who will die in an instance of Ebola, is around 50%. But this has a huge range of about 25% to a high of just around 90%. And that largely depends upon where the people live and if they have access to medical care and what kind of medical care they're receiving. And this impacts what this case fatality rate will look like. The fact that the situational issues are what will impact this case fatality rate is important because that will impact how Sierra Leone may fare coming out on the other side of an Ebola outbreak, like the one that started in 2014. And then just to note, the transmission of Ebola does involve direct contact with infected animal or human fluids. So this includes bodily fluids like blood, saliva, mucus, and then also broken skin, and then mucous membrane, because there are fluids on that. And this is just an image of what the virus itself looks like. So continuing on, some of the symptoms include fever, fatigue, muscle aches, headache, sore throat, so on and so forth. There are widespread symptoms that will develop later on as it becomes more severe, including impaired function of the kidney and liver, some cases of internal external bleeding, which is where it originally got its name as a hemorrhagic fever, but that's not a widespread symptom of this. In fact, a lot of people will die of dehydration rather than hemorrhaging. And there are some lab findings like a low white blood cell count, platelet counts. These are all going to be looked at through blood screenings. And then common diagnostics include reverse transcriptase, quantitative PCR, ELISA, which just uses proteins that light up colors to be able to search for things, serum tests, antigen tests, some microscopy, which uses microscopes. And then there's very few treatments for this, and there's no cure. And largely the treatment is supportive care. That has incredible implications for Sierra Leone because we've talked about lack of economic resources available that are not being shunted towards healthcare, lack of personnel, lack of facilities. And so we can see where maybe as an outbreak occurs, when we need supportive care to be at an all-time high to be able to help people when they're having symptoms of extreme dehydration, they're losing bodily fluids. If we don't have the people to be able to support them, if we know that this is infectious, if we know that there aren't the facilities, that does not bode well for the outcome. So as I said, Ebola, in this case, for this particular outbreak that we're looking at, came into the picture in 2014. And it first showed up in Guinea. But by May of that year, the first reported case of Ebola had already shown up in Sierra Leone. By August, Ebola was declared a public health emergency of international concern by the WHO. Now, I do want to point out that there is about a 3-month gap here. That's a large gap, considering in 2020, it only took about a month for COVID-19 to be declared a public health emergency of international concern. We're talking a 3-month gap here for countries that may not have the resources to be able to respond to what could potentially become a widespread outbreak. By November of that year, Sierra Leone was already seeing its outbreak peaking with greater than 500 cases per week. By May, another spike has occurred. Now, the UK throughout this time period had been aiding Sierra Leone, and they had troops on the ground, both civilian and military, trying to help with this. And they thought that when this large spike had died down, they could leave. They did. And then the spike occurred in May. They have to rush back to deal with it. Once they have, by November, Sierra Leone is declared Ebola transmission free. That doesn't necessarily mean that it's gone. But by January, 2 more people are diagnosed with Ebola Virus Disease, which is EVD. And yet again, they respond. And by March of 2016, Sierra Leone is declared free of Ebola for a second time. After that, we don't see any more of this widespread outbreak. But it is critical to understand that there was a large gap here at the beginning where there was time, it took time for international recognition to be delivered for this outbreak. Some other events of importance that I want to point out involve the MOH, the Ministry of Health Services. Again, it establishes a national Ebola task force. There's a whole bunch of other task forces established throughout this time. And then importantly here in October, one of the units that had been responding to this was actually replaced by the National Ebola Response Center. So this is NERC, and then the District Ebola Response Centers, which are DIRCs. And both of them actually rolled out in October, and they were largely staffed by people from the UK. During 2015 to 2016, the UK really started to decrease its engagement in these response efforts once the outbreaks had stabilized and response architecture was trying to be put in place afterward to be able to mitigate any further transmission. But by November of 2015, we're seeing that the final UK personnel are leaving from the military operations. And then by January of 2016, the majority of the rest of British civilian teams are also leaving. And that's where these NERCs and these DIRCs are decommissioned. So now Sierra Leone doesn't have any of these extra units going through it anymore. They're back pretty much to what they had beforehand, maybe a couple of extra groups helping. But that's about it, which is interesting because this isn't the first time that Ebola's come around, and it probably won't be the last. So that begs the question, what could be left in its place? But before we know what's left in its place, we have to know what the outcomes were of this outbreak. And so it's broadly known that West Africa suffered about 29,000 cases of EVD that were potential cases, both diagnosed, undiagnosed. They just had symptoms that aligned with this. And there were around 11,000 deaths that occurred during this time. That's a large number of deaths that occurred in comparison to the number of infections. Now, in Sierra Leone itself, interestingly enough, they accounted for nearly half of the infections that actually occurred during that period, which is also interesting because they are the second largest country out of the three that were impacted by this outbreak. So they're not even the largest country. They don't even have the largest population, but yet they had the most potential infections. They did not, however, have the largest number of deaths, though nearly 4,000 deaths is still a significant amount of people. What I also wanted to point out here is that we've been talking this whole time about infrastructure and the people and the healthcare workers being an important part of delivering this infrastructure. So it's important to realize that when a population is affected by a disease, the people who have to treat that population are also affected. So we started out with around 1,100 healthcare workers, in this particular case, 1,153, and about 7% of them died because of Ebola or because of something that was related that occurred during this time. That is a significant loss in an already deficient population of healthcare workers, and that doesn't bode well for the future of how the infrastructure responses might be able to be carried out post Ebola. And that's as much a critical part of a response to Ebola as it is for its initial onset, because we want to know if that response is going to be long-term or not. So we know the numbers, but numbers don't equate to people, not necessarily. And we have to keep in mind that this was a population of people that were severely affected, and they've already suffered through so much before this. So what was really going on here? And first, it was noted that there was actually a loss of trust in the healthcare system that occurred during this time. And not just the health system either. This encompasses the public health officials that were in the region as well. And so this actually had its own ramifications, such as the reduction in utilization of health services, which, sure, income is a big thing there, like people pay for services, but even more so is the fact that if people aren't using these services, that means that we aren't seeing cases of Ebola like we should. People aren't getting treatment like they should, simply because of a loss of trust. And this also had adverse impacts on the health workforce and system leadership, because people aren't being seen and they're also not trusting the system either. And then there was a high avoidable all-cause mortality, which harkens back to this reduction in the utilization of health services. We have an impact on the workforce. We have an impact on people actually going to get treated for these things. And so, of course, we're going to have a large population of people dying who really shouldn't have died in the first place, but they did anyways. There's also this feeling of being let down by the system. Not only did they lose their trust in it, they felt like they were let down by it in the first place. And this impacted critical services. So that whole idea of a reduction in utilization of health services also means that critical services like vaccination, which are so important for preventing these large-scale outbreaks, were not being used. Children were not being vaccinated because parents feared for them. And this is a fear of contracting Ebola from needles and from healthcare workers themselves. That is such a big blow to the system, because if we know that it's spreading throughout hospitals now. Healthcare workers are perpetuating this outbreak, and people are afraid of it, and they won't go and they won't be vaccinated. They won't seek out treatment. This just exacerbates an already bad situation, and it makes the concept of transmission of Ebola even worse. And I just wanted to provide a graph to show how vaccination rates actually decreased throughout this time. So we're looking at this in 2014. So in the first few months, we see that they're relatively high, but if we note, it's right here in May that we saw the first case of Ebola, and already by July through December of 2014, there is what looks to be a 50% reduction in the number of children that are being vaccinated. As a significant reduction, and that has an impact not just on the health of the population, but ultimately on whether or not public health infrastructure is functioning like it should and whether or not it's delivering what it's supposed to, because vaccination is a part of this. So we know what the outcomes were. We know how this affected the people. We know the context. We know what Ebola is, how it played out in the country. The responses to it were slow. But what were these responses? What changes happened during this time as Sierra Leone tried to deal with this outbreak in this 2-year time period? So the first one I'm going to talk you through is the surveillance systems for public health. And this is going to include the IDSR. The IDSR is an integrated disease surveillance and response system, and it includes surveillance protocols and systems for data processing and management. And this data encompasses transmission data, the number of cases of any sort of disease that crops up. So this wasn't just applied to Ebola. This is applied to things like malaria, HIV, any important bacterial or viral infection that might be coming through the population. And this is actually required before this. So by 2010, the implementation of the IDSR was required by the WHO for all countries, but most African countries only carried out a partial implementation. The reasoning for that could have many, many different sources. One of them being that whole idea of economic strain. So if we have countries that aren't diverting enough resources to their health system because they can't, then how are they supposed to implement a widespread surveillance system effectively if they don't have the monetary resources available to do so? So during this time period, when we have Ebola coming through Sierra Leone, many healthcare workers were infected. And this actually caused a large number of the facilities to be closed, and this decreased transmission data. So we have the IDSR was supposed to be implemented, only partially implemented. Ebola rolls through. We have healthcare workers coming down sick with it. People aren't even going to facilities like they should. And so we're not even receiving the right amount of data about it that should be coming through. This meant that the IDSR was proposed to be rolled out during this time, so during the outbreak. And so the proposed system for this was that the peripheral units were supposed to record information as they saw it. And this meant that they were taking down numbers on surveillance. And they had a surveillance focal person that would compile it and would send this info to the district level. So you have all these peripheral units that would then send their data up to their district office. And so then a district surveillance person would compile that data, analyze all of it across that healthcare district, and send it to a national office that would then be responsible for taking care of it. They also moved to an electronic IDSR system, and this was made possible by international aid that came through in and installed modems in district level offices, so internet modems, a telephone per peripheral unit, and 10 telephones per district unit to make the resources to be able to give reports efficiently and quickly available to the personnel. There was also trainings that were provided for physicians and other healthcare workers in surveillance and epidemiology. That whole concept that though there is a Ministry of Health Services, their primary healthcare systems were responsible for conducting a lot of this groundwork that you'd normally expect a public health department to be doing. They're doing both. They don't have enough people to not do both, despite the fact there is international aid present. So what happened beyond the IDSR? This includes international support for infrastructure, which was alluded to in the implementation of a fully functioning IDSR system. So the overall issue here is there was duplication of services, dilution of said services, and then a distortion of what limited resources were available. But what did the support look like when it did come in if these issues eventually ended up arising? So Sierra Leone had already been relying on international funds for 20 years, which makes sense, considering all of the issues that arose with a civil war, their own economic issues before that. But this ultimately meant that they were unable to meet social spending floors in many areas themselves. Yet again, coming back to this idea that their economic resources are not available, they're not being expended in the correct ways for the correct reasons. And on top of that, they just don't have enough anyways. Now, when these international supports came through specifically for Ebola, there was the formation of what we would call these parallel implementation structures, which I'll explain a little bit more later. But this included a community health worker program, which was stepping in to overcome shortages and disparities in people. And then they were dependent on outside donors, despite oversight by the MOHS. So Sierra Leone was overseeing it, but outside donors were the ones pumping in the resources. And so they were largely in control of some of what was going on. There was also the implementation of the National Medical Supply Chain, or the NMSA. And this is supposed to handle previous organizations' work. I'm not going to go through what these stand for. All you need to know is that they were supposed to be working with medical supplies. But it was failing like its predecessor before it, the NPPA. And that large part of that is that it needs to establish its own credibility first for it to be functioning. And so it's supposed to be all of these international supports fueling all of their things into this national medical supply chain. And in order to get that to happen, they need this. There were also service level agreements that were implemented during this time, which makes sense because these agreements are meant to help with planning and reduce fragmentation of resources. And this, it was supposed to be done at like the district level, but it wasn't being distributed like it should be. And so maybe there wasn't really fragmentation at the national level, but once you broke down further into the separate districts, fragmentation was beginning to happen and it was rampant. So the last set of infrastructure changes that I really want to talk about involves healthcare, actually. So districts of Sierra Leone were already understaffed. We know this. It's a medical desert. There are not enough facilities, not enough people. But during this time frame, the volunteer community health workers were critical to this cause. So if we don't have enough healthcare workers, we have to supplement that with volunteers, and they were an amazing help. But because of things like NERCs and the DIRCs and other organizations that were being implemented that were paying people, these volunteer community health workers became disenfranchised, and because they weren't being paid for their work, but yet they were doing the same amount, the same stressful, anxiety-inducing work. There's also this issue of infection prevention and control being at a low during this time, which is a really big problem, because that means that what healthcare providers are there are not practicing the appropriate protocols. To put this into perspective, I have two graphs. So this first table here is the average yearly compliance, and this measurement in this assessment tool of hospitals in the Kenema district. And then this is the average yearly compliance in a community health center in that same district. So looking specifically here at sanitation, we see that there's 50% is the score that it was given. And here it's only given 61% at that community health level. While some of these other values look really good, sanitation is important, and issues like personal protective equipment and supplies, as well as sharps safety. Here we have this only at a 78%, and even waste management not being as high as it should have been. The problem, because that means that when you have soiled garments or people or places in a building end up soiled by bodily fluids that may be infected with Ebola, we have transmission. Hence why people in Sierra Leone were afraid to go to the hospital, because they became grounds for the spread of Ebola, because the infrastructure wasn't doing what it should, because the personnel wasn't responding correctly. There wasn't enough personnel, and they were now having deficiencies in any volunteers that could be helping them as well. And this is just to point out again, this is the region that we're looking at here, specifically are these scores. So to provide insight to who these partners were that were so critical to having enough personnel during the outbreak, to putting up really big outdoor hospital centers, or even to just making sure that disease surveillance might have been going on. We have a whole list of groups that stepped in to do this. And this was monetary provisions, as well as other resources like personal protective equipment, and then even the United Kingdom stepping in with actual personnel working on the ground. So now that we know there was the IDSR, which is a surveillance system that was rolled out, we have international aid coming in, though it's not working like it should. And then we also have the healthcare system changing, or it has its own issues, which are reflecting prior problems in the system. What worked in some of these changes, what didn't, and what can we eventually learn from it? So we know that the IDSR was a temporary fix. It was a fantastic fix, actually. They got it working really, really well, but it ultimately was not sustainable. Why? Because some resources were provided, like those internet modems, like telephones, but the country lacks the income to continue with this access. That's the problem here, is that the longevity of the IDSR is in question, not whether or not it could be done initially. We have to see if the country has its own resources to be able to do this. And then ultimately, you also have personnel who must be trained continually, but the availability of personnel is slim. The availability of people who can train other people on it is slim. So how do you keep a functioning surveillance system if you don't have the people to run it as well? There's also multi-level fragmentation. So we noticed those service level agreements were failing, but these partners that were outside, they were giving all of these resources in, they were utilizing multiple systems to do it. So it didn't matter if there's the NMSA that's trying to universalize the incoming medical resources. It doesn't matter if we have these service level agreements at the national level. This fragmentation is still taking place. And so the same thing could be done in 3 different ways by 3 different people, and they don't know what's going on because nobody's communicating that at the ground level. And Sierra Leone doesn't have the agreements in place, the resources in place, nor the structures in place to mitigate that. A country with more resources may not need that aid. They may not have to rely on it. And importantly, they would have the power in place to mitigate any of those fragmentation responses. And that wasn't here. And so this meant, yes, the incoming supplies were disorganized, but ultimately the biggest issue here is those aids have to come out at some point. They have to come back out of Sierra Leone. They're not permanent, not all of them. And yet they left no strategies for exit from the country. So not only is the longevity of a surveillance system in question now, the implementation of medical resources, personnel, monetary resources that could be helping other infrastructure in the country is now not being provided, because instead of trying to find a long-term way to fix this, these countries that came in and helped provided the resources, stepped back with no fail-safe for Sierra Leone to fall back on. There's also this continued lack of trained healthcare professionals during this time, which you've talked about. It's a medical desert. It's a problem, but this contributes to more than just a lack of treatment. This also contributes to an issue with surveillance systems. So we noticed up here that the personnel must be trained continually. The availability is slim. That's true when we look at it at this level as well. We can't do surveillance at any level if there's not the people available for it. There's also this disconnection between the peripheral and district level systems. You have to have the personnel to be able to make it from these PHUs up to this district level. And you have to have enough personnel to make it so that you're receiving adequate and accurate data from one level to another. And that's also not happening. There's a disconnect between that, which is a severe breakdown in the delivery of not only surveillance information, but also healthcare at that ground level for the people in those primary healthcare units and those maternal and child healthcare units. Finally, we noted that there is an infection control issue here. It's inadequate. And some of them were functioning well after Ebola: hand washing, linen sterilization, organization, but overall sanitation is not what it should be. And that could have been one of the things that was contributing to the spread of Ebola throughout hospitals and other medical facilities. Hospitals and community level facilities also varied in practices. We saw that it was slightly different between the hospital level and the community level. The community might have been doing a better job at one thing than the hospital was, but that's still a problem when you have people who have to be transferred to a hospital unit. And that's also a problem because that means that there's not universally adequate care being delivered throughout the country. And maybe that's an issue of the people just didn't have the time. They didn't have the relief to be able to get some rest, to do their jobs as well as they should have. That could also be contributed to by a lack of personnel, as we've talked about plenty before this. And no matter which one it is, it has to be addressed. Just like these other issues of longevity of a system, how do we talk and how do we deal with when the care isn't adequate, when it's not being delivered equally, even amongst a small group of providers? So what are the implications from these issues and these changes? Well, first off, we know that the international organizations offered help, but it wasn't a unified effort, and it certainly didn't pull out the way that it should have. So aid is all well and great, but how do you make sure that it's going to pay off in the end? And that is that response to Ebola that we really care about. Immediate aid is fine, but this isn't the first time this has happened. It won't be the last. And there are ramifications from the outbreak that have to be dealt with after the fact as well. And that probably is, and that's not being dealt with here. We know that there are economic issues that inform the resources available to personnel and the MOHS, but these resources are inadequate to handle these systems and the takeover of these systems. We saw that with the IDSR. They don't have the resources. They don't have the people enough to be backing a whole surveillance system that works countrywide, that works efficiently at every peripheral unit and at every district to be able to send that data up to a national level. We know that it was improved, but for how long? How do we make sure that these systems that were implemented have a lifespan that's worthwhile supporting? How do we know that they're going to be supported? We know that there's a severe lack of healthcare personnel, preventing adequate system function. And this impacted other things in this chain, including clinical efforts as well as surveillance. And ultimately, we know that the people were impacted at that very base level. It's always about the people. And they suffered from distrust of medical facilities because of improper protocol handling, because of lack of personnel, because Ebola was spreading rampant through there. We know that healthcare workers and there's also this mishandling of issues at national and international levels that was compounding this. We know that international organizations were offering help, but it wasn't helping here. And so people were facing the brunt of that. This trickle-down system of aid wasn't making it to the bottom of the system. So what lessons can we learn from this? What's available to us? We know that funding is not enough. We need long-term support for infrastructure, and that requires organized aid. So find better ways of implementing a service level agreements that prevent fragmentation. And maybe that means that these outside countries need to help that country, like Sierra Leone, get those service level agreements to that district level so the fragmentation doesn't occur at that particular part. We also know that the outbreaks, the response to them must be swifter. I mentioned with that timeline, there was a 3-month gap before Ebola was declared an issue of international importance. And maybe that 3 months would have made a difference. It probably would have, especially in terms of Sierra Leone having access to the resources that it normally doesn't have access to. And this should be true regardless of the region where it originates. And that's even more true here because there are social implications because of the way that Sierra Leone was treated in the past as a colonized country, the way that it exists now after all of those years of being colonized and trying to live on its own, and it's struggling. Responses to outbreaks shouldn't be limited to being good just for countries that have those resources. And we saw them trying to help with that here. They tried to develop a surveillance system to help address that. But yet again, this idea that we need a long-term solution still plays in. We know that ultimately, yes, international aid is helpful, but these outside resources get in the way of the help organization, yet again, is key. And that's true of all of the NERCs and the DIRCs and these outside resources that formed with all of these community groups. Maybe they should have found a way to integrate those volunteers in the community into these groups better. Make a wholesome, unified force that can do this. And instead of delivering these resources that were not necessarily, that seemed organized to the outside, to the people looking in from the outside, but not from the inside itself, where they needed to function at their maximum. We know that healthcare and public health personnel, because they function as both, must be aided and they must be supplemented, offer trainings and support, because they're the foundation of the infrastructure of both the public health and healthcare systems for Sierra Leone. We saw that. They focus on primary healthcare. They focus on doing that ground level work. They're divided into districts, into these peripheral healthcare units for whatever reason, but they're still here. And how do you make sure that everything functions like it should? You focus on the personnel. And that means training them, implementing better protocols so that people don't lose their faith in this limited supply of healthcare providers when these outbreaks happen. And maybe this would be a way to help Sierra Leone out more. And ultimately, it's this trust that really does come into play. Public health hinges on the engagement of a population to be able to provide to them resources that can prevent outbreaks, that can address chronic health issues, that can address these population level events. And if they don't trust that healthcare system or the public health people, then the system's not going to function. It's not going to have the best outcomes. And you're going to see what you saw in this outbreak, where 50% of the infected individuals with Ebola were from Sierra Leone, because their people didn't trust the system. They weren't getting treatment because they weren't going in to try to get treatment. They weren't getting vaccinated. And so we're seeing elevated levels of mortality that shouldn't be there, elevated levels of cases that really shouldn't be happening. Trust is key. So what are the overall implementation recommendations that would come from this? What can we take away from Sierra Leone? What can we take away from this case study? Well, first off, we have to address economic issues. This means you eliminate unnecessary spending, like tax exemptions, like having to spend money on helping to build the GDP rather than being able to spend it internally on systems that need it, such as healthcare systems. And yes, that means shunting funding towards those systems to help with the population's health. This also means supporting citizens lacking access to economic resources. We saw this is a medical desert. People don't have access to hospitals. They may not have access to primary health care facilities where they're at either, because there's not enough personnel. Providing them some of those resources might help. And while Sierra Leone itself right now may not be able to achieve that, that's where long-term aid that focuses on building the structure would benefit a country like that. And this also means some of that long-term aid comes in the form of external clinicians and instructors to not only help train practicing clinicians, but to interest other citizens in being trained. Maybe this means starting a teaching hospital to teach people about this. Maybe this means you train people in emergency medicine to be able to at least supplement those peripheral healthcare units. This could have a lot of different functions, a lot of different ways of looking, a lot of different functions. But either way, it hinges on this concept of the system needing to be long-lived, implementing long-term changes. And one of these is interesting because Partners in Health, the PIH, has been trying to do this for Sierra Leone and other countries in West Africa post-Ebola and during Ebola as well. Because long-term support is what's needed, not these brief moments where other countries are freaking out about the same issue that country is freaking out about until they only step in for a brief period of time. And yet again, as I just mentioned, that long-term aid must focus on building current infrastructure, providing support for the process, because you can't just step in and do it for the country and expect that to be enough. It's not. When that country is lacking those resources, when they can't do that themselves, you provide them the tools to do so and help them to establish that. You don't come in, do it for them without ever telling them how to do it in the first place. And ultimately, at the ground level, the base of this, we have to reassure citizens of investment in their health. And that means that when you shunt funding to healthcare systems, when you provide extra clinicians for training purposes or just to supplement a healthcare system lacking in personnel. When you provide long-term aid, you make sure that people know that this is a unified effort, that you're trying to improve their overall quality of healthcare. That you're trying to improve their overall quality of life. And that means that you make them cognizant of how critical public health is to making that all happen, and how they are also a part of that. And their trust is what helps to keep the system running like it should, and making sure that while, yes, there's resources coming in, they are coming in to get those resources and making it worth the time and the effort that needs to go. So I would like to thank you for listening and joining me on this evaluation of Sierra Leone and the lessons that can be learned from this. And here are all of the sources, and for extra information if you wish to peruse this yourself. And I do thank you again. I hope this was interesting, and I hope this was informative for how we can learn about how public health infrastructure and healthcare infrastructure together fuel each other, and how they also have to be working in sync, and what needs to be working in order for a system to work in the event of an outbreak or in the event of a widespread epidemic or a pandemic.